Hello, thank you for joining the latest one on one episode, a video series from Modern Healthcare Custom Media featuring insights from leaders across the industry. I'm Maria Castellucci, a custom content strategist here at Modern Healthcare. On today's episode, it's my pleasure to be speaking with Jim Kendrick, President and Chief Executive Officer of Community Hospital Corporation, a national leader in advancing community owned hospitals. Jim has more than 20 years of experience in executive leadership at for profit and not for profit healthcare organizations. During our conversation today, Jim will offer insights into changes and new practices to consider that will help community hospitals remain sustainable and successful. Key takeaways will be resilient financial models and how partnerships and risk sharing can help struggling hospitals improve their performance. Before we get started, I'd like to thank the sponsor of this episode, Community Hospital Corporation. CHC owns, manages, and consults with hospitals through CHC Hospitals, CHC Consulting, and CHC Continue Care, with the purpose to guide, support, and enhance the mission of the community hospitals and healthcare providers. Jim, thanks so much for being here today. I'm so excited for our discussion.
Thank you for having me today. I appreciate it.
So, Jim, let's start with community hospitals and the situation they're in. Community hospitals have been plagued by many challenges over the years that have unfortunately led to many closures. You're of the opinion that challenges can be an opportunity for innovation. Can you talk about that in relation to community hospitals?
Sure. I think if you look at community hospitals, rural community hospitals specifically through this pandemic, we saw as a nation how critical they are to the success of our overall healthcare system. And, many of these hospitals are chasing such financial challenges that they worry about their sustainability. So, you can't keep doing things the way you've always done them. And as you explore new ways of doing things, you have to be open to all kinds of new ideas. We have examples out there where we're partnering with cities, where we're partnering with counties, where we're taking hospitals through bankruptcy, bringing them out of bankruptcy. We have examples where you're partnering with home health agencies, trying to grow the telemedicine presence. I mean, there's just so many avenues that you have to explore, and there's not a one size fits all for all community hospitals. Some of them are close enough to a metropolitan market where you can partner with a larger provider. Sometimes they're far enough out that they have to be more self-sustaining. Sometimes they have to look at the services that they're providing and determine if they can afford to continue to provide all of those services. Many times a community wants a service, but it may be a loss leader. That doesn't mean it has to go away, but you need to be positioned so that you understand the financial impact of continuing to provide that service. So we see the platform for change is open-ended as any other business. I mean, there's not a single strategy, but when you go out to explore the different models, I think you have to be open to doing things completely different. I mean, there's examples out there like hospital from home. Some hospitals, small hospitals in the rural market may see that as a threat, but it's not really a threat. It's just a transition in care, the way care is delivered in a community hospital. So there's examples like that, examples like trying to expand your service offering in the outpatient setting, which is that's old history, that's old conversation, but it's still relevant today because things that had been shifted to the outpatient last year are far different than things that were shifted to the outpatient 5 years ago. I mean, you have hospitals that are providing total joint replacement and on an outpatient setting where that was unheard of a few years ago. So things of that nature.
That's great. So you're talking about how you can't do things the same. So can you talk about what a hospital should do when they've made the decision that it's time for them to make this big change? What's the first thing they should do?
So one of the things that we recommend for a community hospital is to do a full operational assessment. And that's where you get a good sense of where you're at, what's making your organization successful, what's potentially pulling it down. But that operational assessment covers the entire gamut. What's your service lines? How are you doing financially? What areas were you able to be successful at in the past, but may have changed? Is your productivity in line? Is your revenue cycle in line? Is your overall expense base in line? Is your supply base in line? That's another service that we provide. We see so many hospitals that are paying 20, 10, 15, 20% greater than a hospital, 30 miles down the road for their supplies. And supplies are 20% of your overall supply expense or your overall expense period usually. So having those type of things addressed in an operational assessment is a first step. And I also like to throw into that conversation, not just an operational assessment, but a strategic assessment. Where are you positioned? Are you a sole community provider? or you're a sole community provider in a small market that's far enough away from the metropolitan areas that you really have to look at yourself more from a self-sustaining perspective? Or are you close enough to a metropolitan area where those metropolitan facilities are wanting your business when it needs a higher level of care upstream? Do you have relationships where you are benefiting from the fact that you're aligned with an upstream provider? Or are you simply letting that business flow out? So part of that operational assessment, part of that strategic assessment would be understanding your book of business. So you have, hundreds or thousands or tens of thousands, depending where you're at, patients that are coming through your organization every month. And those patients many times are needing a level of care that you're not providing. Do you know where those patients are going? Where, if you're not able to provide that care, where are they going? Or if you're sending out a large portion of business that you can see through like an emergency room setting, you may be able to say, we have enough volume in this space that this is a new service line that we need to start providing, and then do the math on performing that out to determine if that's a new service line development opportunity. But again, starting with an operational assessment, which includes top to bottom revenue cycle, expense management, the whole component of service line evaluation, and also a strategic perspective on where your business is coming from, where's your business going, what business are you taking care of, what business are you not able to take care of.
So it sounds like what you're saying is it really does depend on your unique needs. So it sounds like there's opportunities for community hospitals to innovate based on their specific needs and the needs of their community. So can you talk about what does that process look like and what innovations might a community hospital make based on those unique needs?
Sure. I'll use an example, a hospital that we partnered with in Gainesville, Texas. Gainesville, Texas was a sole community provider, a hospital north of Dallas, about 45 minutes north of Dallas, almost on the Oklahoma border. And that hospital had got to a point where it had to make change. It was in trouble. It had to go through bankruptcy. So the hospital went through bankruptcy in a defined plan where the goal was to come out of bankruptcy to continue to provide services in the community with those healthcare services, but put it in a position where it was sustainable. So we worked with the district in that community to bring the hospital out of bankruptcy and formed a partnership with the district so that we were in lockstep with them as we move forward to make sure that we were going to make the hospital operate in a different fashion to be successful. That's financial. A financial structure is a key component that someone needs to assess. Many times communities do have some type of financial relationship with a county, with a district, with a city, but they don't always. And sometimes you can evaluate whether or not there is an appetite for a community. If they're worried about losing their hospital, is there ability to put in a tax base? It's not a significant big impact on the tax base, but it is some financial support. So explore those things. In this particular case example I'm using, Gainesville, they already had a district model, but they weren't maximizing all of the government matching dollars that were out there. The LPPF funds, that's a Texas term, local provider participation fund. But as an example, in Gainesville, we weren't maximizing the full value of that particular program. We were able to bring in those additional dollars. Same time, we were able to look at some of our service lines and say, this is not our core area of expertise, but how can we partner and potentially make that better? Home health was a good example. The hospital itself had a home health. That home health operated at a loss, but it was a needed service. So we ended up finding a partner so we could bring that service, continue to provide that service for the community, but bring in a partner that had a greater level of expertise in that space. So now the hospital still has the home health, still has that connection, but now it's in a model where it doesn't have the loss, but continues to be able to provide the service. Same thing from a overall perspective of how are you structured on the revenue cycle was a good example. We weren't collecting all of the dollars that we should have been paid. So we're providing the service, providing the care for the community, but when you would send out the bill, the dollars didn't necessarily all flow back in the way they should. So a revamping of the revenue cycle process, more thorough tracking, detailed tracking, a more thorough understanding of how the dollars should be coming in and matching up that expectation to reality. So starting to collect on the dollars that you should be collecting, so enhancing that revenue cycle. But at the same time, also looking at the expense base. The expenses were not in line with where an organization that size needed to be. So we had to go in and make changes in that. And one of the places you'll find a lot of your expense management is not necessarily in a personnel one-on-one basis. Sometimes it is. Sometimes places are just overstaffed, but sometimes it's the model of your purchase services. What is your contract for ER management? What is your contract for laboratory? What is your contract for radiology? And sometimes these small rural community hospitals, or these community hospitals in general, have been in these contracts for so long, they've never really assessed it. Sometimes they do because someone will come in and say, well, I need a subsidy. So you have a ER group or a radiology group or pathology group, and you may be subsidizing them. But is there a lower cost option? Is there a model where you can go in and partner with those entities and say, if we were to do these things, we think it would improve your numbers. Will you partner with us and create a creative model? I find that there's a lot of organizations out there that are willing to explore creative models, and those creative models are what's necessary to make the finances work in a lot of these rural communities. And then also outside the walls of the hospital, there's so many components that have significant value, and freestanding community hospitals many times don't have the bandwidth of personnel to have all of the expertise that they would have. And that's not a derogatory comment. It's just there's only so much knowledge people can have in certain areas. So sometimes you want that specialty knowledge. Does your rural facility have a rural healthcare clinic? Rural healthcare clinic is a way to provide that physician office type care for a community, and a vehicle where, based off of volume numbers, you may be in a negative situation. But if you structured it through a federally qualified health center or a rural healthcare clinic, or partnered with a federally qualified health center, you possibly can take some of those negative numbers off of your books, but continue to provide the service.
Thank you, Jim. Thanks for sharing that real world example. I know that'll be really helpful to our audience. So CHC is a partner for community hospitals. Can you talk about how does a community hospital know when partnering or risk sharing is the right decision for them?
So, again, you'll find so many different examples of the structure when you're talking about a community hospital. It may be an independent 501c3. It may be a hospital that was built with tax dollars. Sometimes with rural community hospitals, it may go back to Hill Burton dollars that built the hospital. But the structure is the starting foundation of what structure are you currently in, and what are your options. Okay, and then I'll try to I will try to stair step this up a little bit and start with, sometimes you go into a hospital and you realize it's not sustainable. It has so much debt, and the debt service associated with it is not sustainable with the full revenue stream that's there. So it's on a path where it's going to not work. Well, if you're proactive on that, you can intentionally go into a bankruptcy situation, restructure, and come out on the other side with a model that can continue to sustain care of the community. If you wait too long, the different size of bankruptcy may be true closure. So that's what happens with some of these hospitals we've talked about over the years. Not saying they all could have been saved, because they couldn't, but there were probably several of them that, had they started the process earlier, could have possibly used bankruptcy and restructuring. A lot of times people think bankruptcy means you're closed, you're going away. It doesn't. Sometimes it's a restructuring tool to reposition you for the future. And in that conversation, you can go down a lot of different tangents, but debt service, access to capital is a key component for the sustainability of a rural hospital, actually any hospital. But in that model, how are you accessing your debt? If a community hospital has a debt that it's paying and has an annual debt service that is too large, are there opportunities to reduce that debt service? Maybe you take the debt away from a bond structure and move it over to HUD. And if you go over to HUD, you're going to more than likely, almost always, get a lower interest rate, and you're going to get a longer term. So you may still have the same amount of debt, but the debt you're paying is paid in a different format. So that debt will cause it to be considerably reduced. So your annual debt service will go down. At the same time, if you're in a community, and like I talked earlier, it depends on where you're located. But if you're an hour or less, or even an hour and a half sometimes from a metropolitan area, there are a lot of people, as we saw during the pandemic, that are getting their care from their local community hospital. But as they're getting that care, many times you find that there's a greater need for care above and beyond what you're able to provide. And that care goes out to a major metropolitan area. Well, if you have your arms around that, you can look at your data and see that, you sent 450 patients last year to a provider in a metropolitan area that's an hour away. And you can contact that provider, or an organization like us can help you contact the provider and negotiate and work with them to say, look, we send you a lot of business, but we're worried about our sustainability. Can you help us? Okay, not a pay me for referral basis. I'm not trying to go down that path, but I'm going down the path of our community gets care and needs care. Sometimes we can't provide, and it goes upstream to you. But if we go away, that's not good for anyone. So can you help us? Can you put a rotationary basis in place for specialists to come to the community? That's been done forever. But the other side of that is how it's structured. Sometimes the community hospital can actually employ doctors and have a relationship where they're rotating back up to another area. So it doesn't always have to be one direction. It can be both directions. And you'll find that the metropolitan hospitals don't want these rural communities to go away. During the pandemic, there were thousands of examples where patients were in that community hospital and they needed to be transferred up to the metropolitan area, but there wasn't a bed. There wasn't a place to send them. So I think we have some positive aspect of a greater appreciation for the community hospital through the pandemic, and in that a greater appreciation comes in the form of, no one wants them to go away, but from a competitive perspective, and healthcare sometimes is a competitive market. Sometimes people say, well, if it goes away, won't they just get the business anyway? But the reality is no. It gets scattered. It doesn't necessarily have a structured relationship, and people aren't getting the best care, the best delivery model. So one of the things that we want to do is have, where you can, and again, some hospitals are further, more than an hour and a half away from any major metropolitan area, and they have a different strategy. And in those strategies, you got to go in and look at what the community needs, what it can afford to have. And those conversations are difficult sometimes. We get called into hospitals all the time that need help, and they're just doing too many things. They say we have to have an OB program. Well, they're only having 7 deliveries a month, and if you do the math on the program, it's losing $750,000 a year. Well, if they're look at their total financial performance and they're losing $1 million a year and $750,000 of it is coming from an OB program, then you've got to go to them and say, this is costing you $750,000. It may not be the best thing for this hospital or this community to provide. And those are hard decisions sometimes. Now, the other side of that is, if you know that and you get your arms around it and understand this is a loss leader, but it's a community want and need, and then you just simply go out and say, okay, how are we going to fund it? Can we get local support? Could we get a tax base? Is there some other component that can say we will offset this because we want to do this, even though it's not necessarily covering its own financial costs to make it sustainable? It still may be something that we want. Infusion services, there's all kinds of examples where there's going to be things that without a certain level of volume are probably going to be producing a negative draw on your financial performance. Again, our approach is not to say you've got to go cut everything that loses money, but if you have your mind around the things that do lose money and what it's going to take to sustain them or be subsidized in some other manner, that's the best position. At the same token, you can look at the things that are doing well for you, that are profitable for service lines, and say, what do we do to cause this to grow? We make money by doing lab. We make money by doing MRIs, CTs. Those are positive things. Well, where is that business currently coming from? What can you do to cause it to grow so that profitable service line that that you do well in, that you have more revenue growth or expansion of services in that space? And then the same thing I mentioned a little earlier, understanding where your business is going out of your organization and seeing that volume of business. If you looked at that volume of business that's going away, is it something you could pro forma and say, this is a new service line we need to do? We're sending out, and I'm scared to make an example, but we're sending out X procedure, and we noticed that we sent out the X procedure 52 times over the last 6 months. Well, 52 times of that particular procedure may be a profitable procedure service line, and the community won't have to leave to go get it. They can stay in their own market. But again, it's data and understanding your data and doing a deep dive into the data so you can know what you need to continue doing, what you need to stop doing, or if you're not going to stop doing something that's losing your business financially, how are you going to offset that? So a little bit of a ramble there, but
Thank you, Jim. So, a lot of what you're saying sounds like it requires a very strong leader to make these kinds of tough decisions and take a real look at the bottom line and what's going on at their organization. So, can you share an example of a CHC partner that has shown resilience, innovation, it's doing financially strong? What leadership skills are at the organization and what key decisions were made?
Sure, I'll use another example in Texas. It was the hospital in Huntsville, Texas. Okay, the hospital in Huntsville, Texas was, again, a similar situation. It had got to the point where it was going to have to go through bankruptcy, restructure, and come out of bankruptcy and try to continue to provide service. Had it not gone down that path, had not made the decision to go through bankruptcy and come out, it would have closed. Okay, the Huntsville hospital is a sole community provider hospital. It's the hospital. There's a major university in the community. There's a lot of the Texas prison system around the Huntsville area. So there's a lot of people that are employed in that. There's a lot of business that would have lost its only hospital. But because someone made the hard decision, we're going to take this into bankruptcy because it's a path to get us back to a spot where we can rebase and be more successful. At the same time, it took strong leadership with there was a district that was responsible for that hospital. And so those are elected officials. People are voted into those positions and they're making the decision for that hospital and they want to maintain care for their community. You know, they made the decision to partner with someone. They made a decision to partner with us in that particular case. So we partnered with them, brought the organization out of bankruptcy where it was losing millions of dollars before. Now it's making a couple of $1 million a year. Now it's not just printing money and doing amazing, but it is at a spot where it's sustainable to continue to provide care for the community. At the same time, you have to make those hard decisions. The entire leadership team in that organization is gone, and it's got an entirely new leadership team. Nothing disparaging about the previous leadership, but it needed a fresh set of eyes. It needed people to say, why are we doing this? Why aren't we doing this? What can't you have to have a very entrepreneurial mindset on exploring new paths and new opportunities. At the same time, you have to be careful. You know, there's a lot of people out there that'll come in and tell you what you want to hear. They'll tell you, oh, we're going to do this and it's going to do wonderful things for you. But you got to make sure you're being compliant with the rules and regs. You know, I can think of a lot of organizations that got themselves in trouble doing these creative lab structures that at the end of the day got shut down. And then you had organizations that had got themselves in a bad spot because of that. But again, an open-mindedness. The Huntsville market was a good example where it had to choose to go through bankruptcy, it had to choose a partner, had to choose to restructure, and at the same time had to go out and basically look at its relationships. Who could it work with? What doctors in the community? You know, that's the piece that we haven't covered a lot today, but I'll tell you, you know, it still is the only way a hospital can be successful is having good relationships with the medical staff. The medical staff still make the choice to deliver the care in your community hospital. And if you don't have those good relationships, it's very, very hard to be successful. Now, patients come in through the ER on their own sometimes, but at the end of the day, you still have to have someone to provide that care that they need. You have to have that relationship that causes them to be able to get cared for in your facility. You know, having enough business to have a physician interested in a specialty to be on staff at your hospital. And if those math equations don't work for them to be successful, you got to find creative ways to make it work for them so that they want to provide services in your rural community hospital. That goes back to, are you close enough to a metropolitan area to form partnerships? Huntsville, as an example, was. So we could go work with larger providers down the road closer toward the Houston market where they would bring specialists into the market and help where we didn't have enough volume to sustain that on our own. So we had to find a creative model to make that work and partner with those doctors and also at the same time partner with the larger providers in the Houston market, the Conroe market, and bring more business back in. Now, you want to do as much as you can locally. You want to work with anyone that's willing to be in the local market. That's your first priority. But if you have that hole in service and you have that hole in care delivery, you have to find other creative ways to do it. And you know, I have found that there's always someone that's willing to try and work with you. You know, healthcare still is a need in these communities, and people don't want to lose that. And if you find ways to find creative opportunities to partner, there's always someone out there willing to work with you.
Well, wonderful. That was really great advice. So, Jim, we are at time together, but I really enjoyed our discussion. I learned a lot. Thank you so much for being here today.
Thank you so much for having me. I'm, really passionate about the fact that our nation still needs its community hospitals, and we've got to do what's necessary to sustain them. We had a lot of good things through the pandemic that drew attention to the rural hospitals and the fact that they're needed. I think a lot of metropolitan hospitals gained a greater appreciation for what we do and the fact that we are needed. And we just got to work on the federal government system of financial reimbursement to make sure that they prioritize what is necessary to keep rural hospitals sustainable. We're not out there trying to make a bunch of money for private enrollment. We're out there trying to sustain healthcare in rural communities so that when your loved one has chest pain in the middle of the night, they have somewhere close to go to that they're going to get that care and get taken care of.
Thank you, Jim. Well, thank you so much. And I'd once again like to thank the sponsor of this episode, Community Hospital Corporation. For more information about them, please visit communityhospitalcorp.com. And to our audience, thanks for tuning in today. Look for more one-on-one episodes in the coming months by visiting our website and our social media platforms. Thanks so much.
Thank you so much.